Acute respiratory failure can be defined as a state in which the pulmonary system is no longer able to meet the metabolic demands of the body. It can be divided into hypoxemic respiratory failure and hypercapnic respiratory failure. Hypoxemic respiratory failure is defined as an arterial partial pressure of oxygen of less than or equal to 8 kilopascals or 60 millimeters of mercury when breathing room air, and hypercapnic respiratory failure is defined as an arterial partial pressure of carbon dioxide of more than or equal to 6.7 kilopascals or 50 millimeters of mercury. The major function of the lung is to get oxygen in and carbon dioxide out. Getting oxygen into the body depends on the partial pressure of oxygen in the alveoli, the diffusing capacity of the alveolar membrane, ventilation, perfusion, and the relationship between the two. The alveolar pressure is equal to the sum of the partial pressures of the gases within the alveolus, and the partial pressure of each gas is proportional to the concentration of the gas. An increase in alveolar pressure will therefore result in a proportionate increase in the partial pressure of all those gases. An increase in the concentration of inspired oxygen will increase the partial pressure of oxygen while causing a proportionate decrease in the partial pressure of all other gases. Similarly, an increase in the alveolar concentration of carbon dioxide as a result, for example, of hypoventilation will result in an increase in the partial pressure of carbon dioxide and a proportionate decrease in the partial pressure of all other gases. So changes in alveolar PO2 result predominantly from changes in inspired oxygen concentration and alveolar pressure, with a lesser contribution from alveolar PCO2 and alveolar ventilation. Alveolar PO2 is, however, not the only determinant of oxygenation. Diffusing capacity, perfusion of alveoli, and ventilation-perfusion matching are also important. Perfusion of non-ventilated alveoli, also known as shunting, is the most common cause of hypoxic respiratory failure in ICU. Normally, ventilation and perfusion are reasonably well matched, with most lung units having a ventilation-perfusion ratio near to 1. Carbon dioxide removal is largely dependent on alveolar ventilation, which in turn is dependent on the respiratory rate times the difference between tidal volume and dead space. The latter will vary dependent on ventilation, perfusion, and matching. Thus, carbon dioxide elimination is dependent on the respiratory rate, tidal volume, and ventilation, perfusion, matching. Although in theory, acute respiratory failure may result from a low inspired PO2, this is rarely a problem in intensive care, except in locations at high altitude. The other causes of respiratory failure involve abnormalities of respiratory physiology. Under normal circumstances, the alveoli are both ventilated and perfused, with the result that blood leaving the alveolus is fully saturated with oxygen. In respiratory failure due to hypoventilation, oxygen in the alveolus is not replenished and carbon dioxide is not removed. As a result, the alveolar partial pressure of oxygen falls, with a corresponding fall in the arterial partial pressure and hence saturation. Similarly, the rise in alveolar partial pressure of carbon dioxide results in a rise in arterial PCO2. Note that the fall in alveolar PO2 is small and is easily compensated for by a small increase in inspired oxygen concentration. As a result, pulse oximetry, which estimates arterial saturation, is a poor guide to adequacy of ventilation, particularly in patients who are receiving supplemental oxygen. When trying to remember the causes of hypoventilation, it is simplest to think through the neuromuscular mechanism of ventilation and its control, and through the respiratory system problems that might impede ventilation. Disease at any of these sites may cause hypoventilation. Shunting is the most common cause of hypoxemic respiratory failure in ICU patients. It is a form of ventilation perfusion mismatch in which alveoli, which are not ventilated, for example due to collapse or pus or edema fluid, are still perfused. Because the alveoli are not ventilated, blood perfusing these alveoli remains poorly oxygenated, with the result that the blood leaving the lungs is not fully saturated. Furthermore, oxygen therapy has relatively little effect on hypoxia due to shunting. Increasing the inspired oxygen concentration cannot further increase the saturation of blood leaving normally ventilated alveoli, as it is already 100% saturated. And the higher oxygen concentration does not reach non-ventilated alveoli. However, in time, hypoxic vasoconstriction will result in a reduction in perfusion to non-ventilated alveoli and a relative increase in perfusion to ventilated alveoli, thus reducing the magnitude of the shunt and increasing the arterial saturation. Causes of intrapulmonary shunting include pneumonia, pulmonary edema, atelectasis, collapse, and pulmonary hemorrhage or contusion. Shunting can also occur at an intracardiac level, but this is an unusual cause of hypoxemia in the ICU. Any cause of pulmonary hypertension, for example, ARDS, with a patent foramen ovale can lead to right-to-left shunting. The other extreme of VQ mismatch is dead space ventilation. This occurs when alveoli are ventilated but not perfused. Clearly, shunting and dead space ventilation are the extremes of ventilation perfusion mismatch, and less extreme forms of mismatch exist. Indeed, acute respiratory failure is characterized by an increase in the spread of ventilation perfusion ratios, as opposed to the normal situation where ratios are closely clustered around 1. Diffusion abnormalities can result from a failure of diffusion across the alveolar membrane or a reduction in the number of alveoli, resulting in a reduction in the alveolar surface area. Causes include ARDS and fibrotic lung disease. Although diffusion abnormalities are very common, their contribution to respiratory failure is usually small. Clinical signs of respiratory failure can be divided into signs of respiratory compensation, such as tachypnea, use of accessory muscles, recession, and nasal flaring, signs of sympathetic stimulation, such as tachycardia, hypotension, and sweating, signs of tissue hypoxia, such as altered mental state, and at a very late stage, bradycardia and hypotension, and hemoglobin desaturation, which is manifested as central cyanosis. Pulse oximetry is one of the most useful monitors. Oxygen therapy should be titrated to ensure a saturation of at least 90% in most circumstances. Above this level, a large increase in PO2 is required to increase saturation marginally, while below this level, a small fall in PO2 results in a large fall in saturation. Remember that the aim of therapy is to restore oxygen delivery to tissues, and that saturation, not PO2, is a major determinant of oxygen delivery. Oxygen delivery is the product of the cardiac output, the oxygen content of blood, and a correction factor. The oxygen content of blood is mainly dependent on the oxygen saturation and the hemoglobin concentration, with a very small contribution from dissolved oxygen. As a result, it is the saturation which is important in determining oxygen delivery rather than the PO2. There are a number of sources of error in pulse oximetry, of which the two most common are poor peripheral perfusion and a poorly adherent or positioned probe. Both of these errors can be detected with fair reliability by comparing the pulse rate detected by the pulse oximeter with the heart rate determined from from the ECG. If there is a significant discrepancy, the oxygen saturation estimated by pulse oximetry is probably inaccurate. It is also important to be aware that saturation may remain normal in the face of significantly impaired ventilation, particularly if the patient is receiving oxygen therapy. In practical terms, worry if the respiratory rate is more than 30 or less than 8, if the patient is unable to speak half a sentence without pausing, is agitated, confused, or comatose, is cyanosed, or has a saturation of less than 90, or is deteriorating despite therapy. And remember that a normal saturation does not mean that severe ventilatory problems are not present. As always, it is vital to treat the cause, as supportive therapy is futile if the underlying problem is not corrected. Supportive treatment of respiratory failure consists of oxygen therapy, CPAP, and mechanical ventilation. Note that progressive hypocarbia due to a loss of hypoxic drive is rare and that hypoxia kills. The appropriate response to progressive hypocarbia, therefore, is assisted ventilation, not removal of oxygen. Reservoir face masks can deliver up to 70% oxygen, depending on the oxygen flow rate, but need to be adjusted so they are tightly applied to the face. Otherwise, it's easier to entrain air from around the mask than to inspire oxygen from the reservoir bag. Other oxygen delivery devices include bag valve resuscitators, which supply 100% oxygen if applied tightly to the face. It's important to realize that adults, but not young children, can breathe spontaneously through a bag valve resuscitator. High-flow nasal cannulae allow the delivery of humidified gas with a high oxygen concentration. The high flow provides CPAP if the patient keeps his or her mouth shut, and the turbulent flow results in dead space gas in the pharynx being washed out. For patients with respiratory failure, which is predominantly due to shunting, CPAP may improve oxygen dramatically by reopening and keeping open collapsed alveoli. This recruitment of alveoli increases the functional residual capacity, shifting the patient to a more compliant part of the lung volume pressure curve, and thus reducing the work of breathing. CPAP is particularly useful for patients with acute cardiogenic pulmonary edema, as it reduces preload, afterload, and decreases myocardial oxygen consumption. The decision whether or not to ventilate a patient is a complex decision which takes into account many factors, and as a result, there are no simple rules for when to ventilate a patient. Major factors to be considered include severity of respiratory failure, cardiopulmonary reserve, patients with low reserve should be ventilated earlier, adequacy of compensation. When considering this factor, the likelihood of adequate compensation continuing should also be considered. Patients with a high ventilatory requirement are more likely to become exhausted and decompensated. Expected speed of response to treatment. This will depend not only on the underlying disease, but also on the treatment that has already been given. Thus, a patient with an acute asthmatic attack who has continued to deteriorate despite nebulized salbutamol and oral steroids is unlikely to respond rapidly. Risks of mechanical ventilation. These vary with the underlying disease. For example, the risks of mechanical ventilation in acute asthma are greater than the risks of ventilation in acute pulmonary edema. Non-respiratory indications for intubation. For example, the patient may require intubation and mechanical ventilation for surgery. Whenever considering mechanical ventilation, consider whether the patient be ventilated non-invasively, as this is generally associated with a lower risk of complications. These principles are best illustrated by clinical examples. The first is a 43-year-old male with community-acquired pneumonia who was started on appropriate antibiotics the previous day. On 15 liters per minute of oxygen via a reservoir mask, His arterial blood gases show a PO2 of 8 kilopascals, 60 millimeters of mercury, PCO2 of 4 kilopascals, 30 millimeters of mercury, and a pH of 7.15. His respiratory rate is 35 per minute, and he's agitated. Should he be ventilated? Decide what you would do. I'll give you a minute to think about it. The patient is hypoxemic, despite near maximal oxygen therapy by face mask. His tachypnea also indicates that his respiratory failure is severe, and his agitation and metabolic acidosis indicate tissue hypoxia. Furthermore, he's only on the first day of antibiotic therapy for community-acquired pneumonia, and he is therefore unlikely to respond rapidly to treatment of his underlying condition. The risk-benefit ratio therefore favors ventilation. The second case is a 24-year-old woman with acute asthma. She's been using a salbutamol inhaler but has not received steroids. Her peak flow is 60 liters per minute. Her heart rate is 105 per minute. PCO2 is 6.8 kilopascals. That's 60 millimeters of mercury. The respiratory rate is 35 per minute. She's alert. Would you ventilate her? Again, I'll give you a minute to think about it. Although she has severe asthma, as indicated by her low peak flow, tachycardia, hypercarbia, and tachypnea, she is alert and has received relatively little treatment. There is therefore a significant chance that, with appropriate treatment, she may improve significantly in the next few hours. Furthermore, her underlying problem is asthma, and ventilation of patients with asthma is fraught with difficulty. The risk-benefit ratio is therefore less in favor of ventilation in this case. Okay, so now I'd like you to write down 3 key learning points from this lecture, 3 things you think would be important to tell a colleague who did not listen to the lecture. I'll give you a minute to do this. Remember, shunting is the most common mechanism underlying acute respiratory failure in critically ill patients. High inspired oxygen concentrations are required, and treatments that reduce shunting, such as CPAP and high flow nasal oxygen, may be particularly helpful.